Okay, hello everybody. I'm Jackie Druin, and I'm the president of the World Congress for Physical Therapy's Oncology, HIV/AIDS, and Hospice and Palliative Care Network. I'm really happy today to be able to introduce Virginia Pier. She's a colleague from California in the USA, and she's going to be talking about bowel, bladder, and sexual function after cancer treatments. So Virginia, I'm going to let you take it away here.
Great, thank you. So good morning, welcome, and as Jackie said, I'll be talking about bowel, bladder, and sexual function after cancer treatment. It's near and dear to my heart, and I am not the type of presenter that enjoys just reading off the points, so please feel free to interrupt me at any point. So, speaking of points, the main points that I hope that we'll all come away with is understanding the types of cancer and treatment that affect the urogenital system, bowel, the pelvic floor, and the ability to function sexually or sexual function. Identifying what these symptoms are for urogenital, bowel, and pelvic floor, asking the right questions to find out if these issues are happening, and what are some of the treatments and the recommendations that we can make to help reduce the symptoms that our patients are having. And also, I hope this is what I really hope everybody comes away with, is that physical therapy is a very, very important part of the oncology team. And now, let's see, we've got that. So Jackie, just to, if there's a few awkward moments here, it's because I am working off of a Mac, and my PowerPoint doesn't like Mac, so Jackie has the ball. So the learning points are that you can recognize what these impairments are, that you'll have a sense of constipation, diarrhea, vaginal irritation, frequency of bladder and bowel. Also, you will be able to provide basic education and treatment for these issues. And if you're not comfortable, you'll have a very good idea that, oh, I'll send them to the pelvic health specialist. And knowing when you should refer to somebody who does specialize in male or female pelvic dysfunction. So the type of cancers, and I'm very much focused on the pelvic cancers in this presentation. There are many other cancers that may also have secondary issues involving the pelvis, but these are the main ones. So these are the ones that I chose to talk about today. Breast obviously is not in a cancer in the pelvic region, but it does. There are some treatments that do affect function in the pelvis. Prostate cancer, colorectal, anal, uterine, cervical, ovarian, and testicular all have very direct links between the treatment, the surgery, and pelvic dysfunction. And some of the treatments here that I've mentioned, or I got up on the screen, are chemotherapy, hormonal therapy, if somebody has a colostomy or an ostomy, immune modulators, radiation therapy, and surgery. And if you're going, I don't know what that is, I will be talking about them, so hang on. Just a background on breast cancer that I think most of us know already, but it's the most common cancer among women. The risks for developing long-term side effects after treatment often are age. The older you are, the more likely you are to develop symptoms. I added body mass index, and I'll be honest, it's not so much for the pelvic dysfunction, but for those of you that are lymphedema therapists, BMI is a very big risk factor for developing lymphedema. So I just thought I'd put it in so I could do a little shout out for that. The type, dose, and duration of treatment has a big influence on whether or not people will develop symptoms. Okay, so the real driver for these gynecological side effects for breast cancer patients are the estrogen inhibitors, especially the aromatase inhibitors. And what women will frequently experience is a very large, precipitous drop in estrogen. And that creates a cascade of events. And the side effects include the decreased blood flow to the vaginal tissues. And when that happens, there's significant dryness. The lining of the vagina thins. And when that, and I want to add that the urethra is also an estrogen-loving organ, as well as the vagina. So when it loses estrogen, the urethra also thins and dries, the lining does, and that creates a lot of urgency and frequency. The bladder has some estrogen receptors, and so it too is affected. Obviously, if the vaginal tissues are thin and dry, it can cause a lot of pain with intercourse, and certainly hot flashes are a misery. This is not so much for pelvic health, but bone loss is significant with women taking the aromatase inhibitors. And now they've got most women on Zometa, which helps to reduce the incidence of osteoporosis, but still they have to be. And I do want to add, patients may not, in fact, I would say probably 90% of them are not going to volunteer. Oh, you know, I'm having trouble with sexual intercourse, especially if they're there to see you because they have a swollen arm or their shoulder is bothering them. So it's something that we need to ask them. So, the one thing I did forget here is that when we've lost estrogen and the bladder is irritated, urethra is irritated, there's pain with intercourse, it's not uncommon to see the pelvic floor tightening up. And there are some really nice stretches that I'll talk about later that can be helpful. But at this point, these folks may really need to see a pelvic specialist. Also, I just to mention that some women will have the total hysterectomy and the bilateral salpingo-oophorectomy. So at that point, if they've got that, they've had everything taken out and they're on the aromatase inhibitor, they are going to really struggle with that one. So if the pelvic floor becomes really, really tight, there may be some pain that can be felt in the abdominal wall. And there is, let's see, Jackie, can you scroll up just a little bit on the slide, just a tiny bit, because there's a note there that I want to come up. Yeah. Oh, well. Oh, yeah. Okay, there we go. So during the surgery, occasionally the low sacral nerves, the S2 through S4, that would be the pudendal nerve, get irritated, and that can cause these spasms. And a lot of times they'll be felt in the abdominal wall. So that might be something to think about if you have a patient you're seeing for breast cancer range of motion or lymphedema, and they're talking about pain in their lower abdominal area. Okay, so on to the next slide. So I like this slide because it shows a nice split between a healthy vagina, where if you look on the healthy side, and on the far, well, if I'm looking at it from stage view, on the left, the stage left is over. Yeah, it's the box. Yeah, there you go. You can see there's lots of nice big blood vessels, and that the tissues are nice and plump, and that the ovary is all happy and full, and that the uterine lining is nice and thick, and the vaginal lining is nice and thick. And then you look on the vaginal atrophy side, and there's a much less blood flow. The lining is quite thin, and not only that, but the vaginal canal actually shortens. And then on the other side, with the bladder, one of the reasons that we can get urgency is if the bladder is irritated, its response is to spasm. When the bladder spasms, we may feel like, oh my God, I've got to go right now. The loss of estrogen can also cause the skeletal muscle to weaken over time, so that can also be a contributing factor to incontinence. And I do also want to mention, just as a precursor, that it's not just the loss of estrogen, but if women have radiation for, let's say, anal cancer, rectal cancer, any of the cervical, uterine, or vaginal cancer, that can cause a lot of thinning and certainly a huge decrease in blood flow. So that's a big problem as well. So next. Okay, so I wanted to have these lovely pictures up because, especially the one on the right, which is the one with all the nerves, the pelvic bowl is just a huge receptor. It's like a huge freeway interchange with lots of different roads, e.g. the nerves, coming up and down through this pelvic area. And what's very cool is that the pudendal nerve has roots and cords and branches, and it acts like, I guess you'd call it, the pelvic version of the brachial plexus. So with surgery to the pelvic region, it's not too uncommon. It's a possibility that there can be some disruption to the pudendal nerve function. And if you look on the left side, you can see it's a much less complicated version of the pudendal nerve, but you can see the rectal plexus, which is, well, it's really teeny, and I'm pointing, you guys. I'm sure you can see me pointing. So Jackie, can you see? Yeah, rectal plexus is right up there. So let's say somebody has rectal surgery for cancer and they have radiation. Those nerves are more than likely going to have some disruption. And the pudendal nerve is more at the base of the pelvic area. It's the long, thin line. It's right above the adipose tissue, and that runs forward, and it serves the urethra. It serves part of the rectum, and it's very, very important, obviously, for bowel, bladder, and sexual function. It serves both the clitoris, and it's the dorsal nerve of the penis comes off the pudendal nerve. So we are moving on to slide 10. So here I have this just so you can get a visual on what the pelvic muscles look like, and everything's stripped out. Obviously, this is very simplified, but here are this wonderful group of muscles that keep us continent. They allow us to have babies, to defecate, to urinate, and function sexually. And they have a heck of a time after we have had surgery, we have cancer treatments. All of those things take a toll on the pelvic floor. And I'm going to talk as we go on more about some of the things that we can do to help mitigate some of these treatments or the effect of the treatments on the pelvic floor. So here we go, and we're coming up to prostate cancer. So this is a much more common cancer in industrialized countries, and the reason that's given is that the industrialized countries have a higher fat diet, and those that are eating more fruits, vegetables, and whole grains have fewer incidences of the cancer. And there are a lot of variables that determine the degree to which somebody who's had prostate cancer surgery and treatment is going to develop incontinence and sexual dysfunction. I'll tell you that since the robotic-assisted laparoscopic surgery, it's gotten a lot better for men. It's still not great, but some of these variables include the location of the cancer, the stage of the cancer, how aggressive the cancer is. If somebody already has had like a TERP, that's where they ream out the urethra that's going through the prostate gland. And all those things will make a difference to their response to treatment and also their response to physical therapy. So next. Okay. So I talked already about some of these factors, and I didn't mention lower urinary tract symptoms. So, and that's a lot of older men will get frequency and urgency, and basically it's when the urethra starts to, not the urethra, when the prostate starts to grow, it puts pressure on the urethra, and that's when they have to go in there and literally open up the space in the urethra. So it's not very pleasant. The pelvic floor may be in not such great shape, although with men that's usually not such a problem. If there's any fibrosis in the prostate area, the pelvic area, and how is the nerve supply to serving the prostate and the pelvic floor and the sphincters. Surgery can have a big impact. There's many blood vessels, and the nerves serving the prostate and the urethra are massive. We're about to see them in just a minute. So next slide. So this is a really baseline picture. We have the, let's see, the rectum is right behind, so you can see it, you know, it's a big open space. The pelvic floor is the two little, Jackie, if you move up just a teeny bit, yep, there you go. That's the anal sphincter right there. And then if you move across there, if you find the prostate, which is below the bladder, the big brown balloon, yep, and you've got the seminal vesicle that's coming, there we go, there's the seminal vesicle, and it's the tube, if you will, is coming down. That's the ejaculatory duct, and then the urethra is coming down from the bladder, and the two vessels converge and form the urethra. So we have a lot of complicated stuff, and that's just the complicated anatomy, and we haven't even got to the nerves and the blood vessels. So on slide 14, we can see different tumors, and I gotta laugh. Does this not look like a martini glass here, like a pink martini with, well, the seminal vesicle is the funny looking thing over to the left, but it looks like it's like a stir, a drink stir. Anyways, the red is the tumor, and that's a stage 1 tumor. So that this person could be lucky because it's not impacting a lot of structures. If you move on to T2, we've got a stage up, so that means it's going to be greater than 2 centimeters here. There's a potential for there to be some problems as it is starting to impact the urethra and the ejaculatory duct. Then down on the far left, we see T3, and now we're starting to have some problems because it is going to be impacting not only the prostate, but the urethra and the seminal vesicle, and probably quite a number of nerves and blood vessels. And with T4, we're now metastatic, and we're affecting not only the bladder, the seminal vesicle, the urethra, the ejaculatory duct, the nerves and the vessels, and this poor individual is probably going to be incontinent. I'd be really surprised if they did particularly well. So, next. And here, I am showing this because I love that it looks like a mess, because that's exactly what it is. If you do a dissection and you look at the pelvic floor, it is mind-boggling. The complexity and the number of vessels, nerves, blood vessels, lymphatic vessels. It's just, I'm going to say again, mind-boggling. And the fact that we function as well as we do. But if you look at the if you look at the bladder, and you can see that there's a lot of nerve endings serving the bladder. We've got many of these nerve endings coming over the rectum, which is behind the bladder. So the yellow, all these nerves that are covering what you can kind of sort of see, that's the rectum. And boy, you can see how much it's a big thoroughfare for the nerves. And the pudendal nerve is coming off. If you go further back and you look flat up against so you go back, yep. So here we have the sacral plexus, and it too, this is where the pudendal nerve root's coming off, and it crosses between the piriformis and the coccygeus muscles, and it's a very complicated little route. It goes outside of the greater foramen, and then it comes in through the lesser foramen, and it wends its way between the pelvic floor and the obturator internus. So it's really right down at the edge of the pelvic floor. So that's your brief anatomy lesson on the nerves of the pelvis. Going on to the next slide. So what are the effects? So stress incontinence is very common, as is erectile dysfunction, and often one or both of the urethral sphincters get affected. And there are two sphincter muscles. There's the internal sphincter and the external sphincter. The internal sphincter is not under our control. It's a sympathetic sphincter. The external sphincter is a motor nerve. So sometimes they're stunned, sometimes they're not. Jackie, can you scroll the slide up just a little bit? I just want to see some of my notes so I can remember. Yeah, okay. So usually it takes about a year before these nerves are going to regenerate as much as whatever they can regenerate. And so if somebody's going to regain their continence and erectile function, it's usually about a year, but clinically, I would say it's perfectly reasonable to tell somebody it might even be 2 years. Radiation therapy is a huge, huge issue for these folks because when you have radiation therapy, it affects both the rectal nerve, it affects the dorsal nerve, and so therefore you may see urinary and fecal incontinence. It can cause proctitis, which is a really nasty inflammation of the rectum, or you could say rectal anal canal. It's a very, very common issue after radiation therapy. And with proctitis, patients may describe very, very painful experience with defecation. Vaginal intercourse can be very painful. There is stenosis as the irradiated tissues heal. The tissues become much less flexible and they start to tighten. It can cause inflammation of the urethra and the bladder, which can lead to urinary urgency frequency. So while radiation may save lives, it also can make the quality of life very unpleasant for many people. And that's where we, as physical therapists, can make a difference, and I'm going to talk about that later. So going on to androgen deprivation therapy, those are hormones that are used for men who have more of an aggressive cancer or one that they feel might be a little harder to control. And what happens then is that because they're knocking out the testosterone and mostly all the androgens, basically, because it says androgen. So you've lost your testosterone. So estrogen, the hormone estrogen then suddenly becomes dominant. And what happens is there's gynecomastia, erectile dysfunction, and osteoporosis is really common. Cardiovascular disease, incidence of diabetes goes up. So these folks are at risk for fractures, heart attacks, strokes, and another population that is probably underserved. So next, I have this up on the screen because it really shows nicely the radiation field. And what you can see, the black line is obviously the radiation field. And the orange in the back, the funny looking, looks like a little seahorse, the rectum. The anterior rectum is going to be most affected here. Obviously the seminal vesicle and the prostate. And the posterior and inferior side of the bladder are going to be affected. And so this individual is probably going to have both bowel, bladder issues. Okay, next. So colorectal cancer gets the honor of being one of the most common cancers in the industrial world. In the United States, it's the third most common, and its treatment is mostly surgery, chemotherapy for some, radiation, and what I'm noticing a lot is that they're seeing more concurrent chemo radiation. It's not uncommon to see a colostomy bag afterwards. In fact, I would say almost all of them have that because they have to let the colon heal. And then an ostomy bag for some. I actually had a patient who had colon cancer, and she recovered okay, but she had such terrible diarrhea, and she just could not control her bowels. She said, "This is it. I don't care. I want an ostomy." And she is one happy camper. So even though they've got a bad rap, in some cases they can be a real lifesaver, just in terms of being able to function. All right, on to the next slide. So I had a lot of fun looking up pictures, and I love this one because up on the upper left-hand corner we have a beautiful normal colon, and it's plump, it's healthy, it's not discolored. And then you go over to the far right, and here we see an illustration of rectal cancer. So there is inflammation, which we can tell because it's swollen. If you look deep into the canal, you can see what we call an ulcer or lesion. That's that red spot there. And and that's probably where if somebody was having symptoms, it was probably from that spot, and that's where they're going to have that bright red blood in their stool. If we go down, directly down, doesn't matter, then we have the descending colon cancer. And again, we have a nice sense of this is not a happy colon. There are obviously inflammatory markers. We've got a lot of redness. We've got swelling. If you compare the normal colon, the orifice is nice and open, and this is not. So I would imagine this would be kind of painful. And then over to the far left, we have rectal cancer, and we can see that there's inflammation. There's what appears to be a rather nasty tumor on the upper left corner, and I'm sure that was creating some bleeding and probably some discomfort during defecation. So, on to the next. And so what are some of the effects? Well, many of which I've already said, but I will read them off. So bowel and bladder incontinence, and it's more about the treatment than the actual cancer, at least in the beginning. Chronic diarrhea, which should more than likely be maybe from the chemo sometimes, but very much so during and after radiation. It's extremely irritating to the healthy gut. excessive gas, rectal stenosis, gut wall inflammation and fibrosis. If somebody has, well, they're going to have surgery. So if they have surgery and they're concerned and they're going to do the radiation, it's not unlikely to expect there's going to be some fibrotic tissue, which is going to cause some pain for the patient. That proctitis, that inflammation of the rectal, anal tissues is very common. The nerves of the pelvis may be affected by some of this radiation, and especially if it's rectal cancer. Maybe not if it's high enough up in the colorectal, or I should say high enough into the rectum and it's going up to the sigmoid, they might be okay with erectile and function and even urination, but it's going to be more of a problem if they have radiation. It's a problem for women with orgasm. Some of it's from pain, some of it's from disruption of the S2, S3, S4 because the pudendal nerve is so near the rectum there. And obviously emotional distress and depression is a big deal. So if your facility or you're in an area where you have some good counselors, psychologists, really nice to be able to say, hey, if there's somebody you want to talk to, I know of someone. And next. Okay, so this is a little bit of a close-up, so don't need to go into too much detail here, but if you look at picture A, when I talk about strictures, if you go up between C and D, yep, there is a nice stricture, and that you can see over here. If you go over 2, it's on the far right on the top. It's not what I would have thought a stricture looks like, but apparently this is, for this stricture anyways, so it's tightened up and the passage of food, fluid, all the waste matter, well, it wouldn't be food, it would be waste matter, is not going to have an easy time of it. The bottom 3, you can see more of the inflammation, swelling. So I think it's a good illustration of this is not fun for anyone who's ever had to experience this. Okay, next slide. This is a picture of proctitis after radiation, and you can tell that there's a lot of damage in the tissue. This is usually proctitis occurs from the anal opening up about 6 inches into the rectum. And it's really common. I'm kind of repeating myself here, but always good to hear it more than once. If somebody's telling you that they're always having the urge to have a bowel movement, if they say, you know, I have a bowel movement, but my rectum still feels full, or I'm constipated all the time, that, and they've had treatment for a rectal or an anal or a colorectal cancer, this may be why. And they would probably, if they haven't talked to their doctor about it, it would be a good idea for them to do so they can get, so they use like a cortisone kind of cream that helps to calm it down. And then when that's calmed down, either you or a pelvic specialist can work with them. And there's moderate to mild irritation, and I'm saying that sort of sarcastically. Does this look like that would be mild or moderate irritation? But that's what the article said. All right, next. So anal cancer is not that common. Although if you think about it in terms of the millions of people that we have in the industrialized world, it's a fairly hefty number. It is more common in women. They're not exactly sure why folks get it, but what the thought is currently is that if you have the human papillomavirus, we've had a history of it, if you have HIV. Now, I wrote down exactly what they said, sexual activity. Well, I'm going to add something to that and say sexual activity with multiple partners. I think that's what they must have meant. Receptive anal intercourse in men. They didn't say with women, although I think you got to add women too. If you have a compromised immune system, and that would obviously fit right in there with HIV, and if you smoke cigarettes. So that's some risk factors there. And on to the next slide. So I have this slide here, and unfortunately, what it says is tumor response to something alone. I can't say bevacizumab alone, and to a combination of that chemotherapy with chemoradiotherapy. But what I couldn't find the comparison slide, but what I love is that if you look at the pre-treatment slides, those look just dreadful. They're inflamed, they're red, they just look like, how could anybody feel good? It was just like, wow, this is not okay. So then you go down to 7 weeks post-treatment, and this chemotherapy has, well, again, I don't know which patient received which treatment, but they all look considerably better to me. And so I just wanted to give you a sense of the before and after, and I must say I'm pretty impressed. And I wish I knew more about histology to see, what those slides meant in terms of improvement. But just thought it was a very interesting slide. And next. So what do they do for anal cancer? It's not that dissimilar to what they do for colorectal cancer. And the side effects are quite similar as well. Diarrhea, rectal bleeding. The pelvic floor symptoms are a lot of pain and with defecation. And when I say anal sphincter dysfunction, I mean it's either not working well because it's been, quote, stunned by the radiation or the surgery, or it's tightened up too much. Fibrotic tissue is quite common around the surgery site or the irradiated site. Proctitis is extremely common. Radiation dermatitis, which is very closely related to proctitis. I would say it's more likely to occur in the vulvovaginal tissues simply because they are extremely delicate and it doesn't take too much to irritate them. Skin ulcerations and necrosis are common after radiation. Then we have the urinary symptoms, which are similar to what I've said before: burning during urination, urgency, mostly because of that irritation, and stress incontinence, and that's because the anal sphincter, well, sorry, not the anal sphincter, the external urinary sphincter has been irritated along with all the rest of the pelvic floor. Vaginal stenosis and erectile dysfunction is common. And I have here that there is a decrease in erectile function. So what this says here is that there are certain levels. The first is you're normal. The second is you have some dysfunction, but if you take something like Viagra, you're okay. And the third level is even with the Viagra, you're not okay, and you really need something like a penile pump or an implant. So next. So these are the rectal cancer imaging fields, and you can see here that the rectum is obviously going to be targeted, as is the anus, but the bladder is in that field of radiation, and the vagina, although it may not be right in the target, it's going to be affected. And then we're going on to the next slide. So this is called intensity modulated radiation. And there is less damage to the tissue because it really is like 3D. And they are able to target the tumor quite specifically. And so where you see in the orange, or the deep kind of reddish orange, that's where they're targeting. And you can see at the upper left, there's the anus there, and that you can tell is really getting hammered. No, it's further. Yeah, there you go. There we go. And that's the main focus. But if you move over towards the front, anterior, because that's obviously posterior. Yeah, and inside of the orange line, you can see that posterior bladder is getting the heavy hit that the anus is getting. The front of the bladder isn't. And I honestly was having trouble figuring out which sex this was, but it really doesn't matter. Probably, I think it's a man. But anyways, so then you can see that there's some spillover into up into the colon itself, but not nearly as intense as it is in the rectum. But it looks to me like this person would have some urinary issues as well as all the anal rectal issues. Okay, next. So this is a view of radiation-induced proctitis. And what you can see, the rectum, if you look on the bottom left, this is the pubic bone, right? A little up, a little further. Yep, pubic bone. The bladder sitting right above it. Yep. And then behind that, you have the rectum. And if you go up a little bit along the rectum, you see it's not a bad passage. That's going to be probably the sigmoid there. So we want, no, actually that's your prostate, I think. Yeah, that's the prostate. But if you're going to move over back to the rectum, so you're going to go to the left, yep, right, and you come down, keep coming down, yep, right in here. You see how narrow that is. That is, I would call that stenosis, not proctitis, but great illustration. Then if you move over to the sacrum and the tailbone area, the coccyx, you can see that there's a lot of tissue in here, and up and then down a little bit further, there's a big ball of tissue there, coming down, yep, nope, come up, yeah, there you go, yep. That is fibrosis, and that's not pretty stuff. And that's going to cause some trouble with bowel function. It may interfere with some nervous function. So again, I keep saying it, radiation will save you, but it can cause a lot of quality of life issues going forward. All right, so next. Okay, so we have cancers of the cervix, the endometrium, and the ovary. And just some brief stats here. Of the sample that they interviewed, 43% reported that they had moderate fecal incontinence. 42% had moderate to severe urinary incontinence, and just under 30% said that they had emotional reactions such as fear, disgust, shame, and guilt. So, and 40% had either few or no orgasms with intercourse. So what this says to me is that here's a population of women who have some serious issues that are mostly going unnoticed. And I think part of it is because we're not asking, and part of it is because they don't think that there's anything that can be done. So it would be nice if we started to ask, and for those of us that do women's health, that we begin to work with them and see what we can do. All right, next. So you might be thinking, well, what questions am I supposed to be asking? I don't know. So I have here, this could be a cheat sheet if you'd like. You would just be straight up. If you're with a female who you know has had cancer, you happen to see it as you're doing a chart review, you ask if they have urinary incontinence. Do they have burning during and after urination? Are they having pain with sexual intercourse? And I'm going to talk about a sexual dysfunction scale later on. Are you having trouble with orgasms? Do you feel like there's enough lubrication during intercourse? You having diarrhea, constipation? Is it painful when you defecate? Do you feel like you have a heaviness or pressure in your pelvis? And that would then be, aha, maybe they have prostatitis. And then for males, asking if they've had prostate cancer and you feel comfortable with it, you ask, are they having erectile dysfunction? Are they having pain with intercourse? Are they having urinary urgency or burning after urination? Diarrhea, constipation, pain with defecation. So they're very similar questions for both the male and the female. And also asking them if they want to speak to somebody. You know, we have our instincts, and I think we can sometimes tell if somebody's really uncomfortable. But I think this is a very important question to ask. Okay, next. So this is not the Marinoff. I couldn't find that, but this is a brief sexual symptom checklist for women that is actually recommended by the American College of Gynecologists. And it's really simple, and you could just hand it to them if you wanted to, or simply ask them the questions. Next. And this is an erectile dysfunction score. Honestly, I think it's, well, you can either ask them or give it to them. I like the next slide a lot better because it's simple, direct, and it gets right to the point. Simply, I mean, tofu. I mean, the penis is large, but it's not hard. That makes sense, right? A peeled banana, it's hard, but not hard enough for penetration. An unpeeled banana is hard enough for penetration, but not completely hard. But a cucumber is the real deal. And I suppose some people might take offense at this, but hopefully most people wouldn't, because I think it's just so beautifully simple and to the point. All right, next. So I have this here so that we can all see what the medical treatment is and the surgical treatment for men after they've had prostate cancer. They are using vasodilators like naltrexone, and obviously Viagra is a very popular medication. It does work well for some, but not so much for others. And then it literally injecting vasodilators or implant into the penis, and then an implantation of a prosthetic device. And I don't know what this last one is, Uprima. It apparently increases the dopamine availability in the brain. So good to know what those are. That's obviously not what we as physical therapists are doing. So the gynecological and side effects to radiotherapy in the pelvic region, I've pretty much gone over them. I'm trying to think. The one that I would add in are two at the bottom, which are pelvic fractures in older women. So it's going to put us at risk there, especially if somebody already has osteopenia and lymphedema. There's a number of there's the para-aortic and the pelvic nodes, and they do tend to remove quite a number of them, especially with the ovarian and cervical cancers. And I have had some women who have come to me after this surgery for lymphedema. So that's something to consider as well. The radiation effects, you can expect at least 2 years of, I think, at least 2 years of fairly acute, unpleasant symptoms. If they are not treated with a vaginal or a rectal dilator to help with the stenosis, that can become a real issue down the road. Okay, next. Okay, I showed this slide before, and I'm showing it again because I want you to look again at the vaginal atrophy. That's what happens with the radiation, and not only is it atrophied, but it's stiff and very inflexible tissue. The bladder itself can become a bit stiff because of radiation, so it's not, it may not have its same filling capacity. You may not be able to empty as effectively because it can't contract as effectively. The pelvic floor muscles may have been affected, so they're not contracting or relaxing as effectively either. We cannot make a change to the bladder, obviously, but we can make a change. If we see these people soon enough, we can make a change to their pelvic floor and by default to the sphincter muscles. We can make a change to the patency of the vaginal canal and the anal opening and the rectal canal. So please, 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 all of us, if we see somebody's had radiation, ask if they've seen a physical therapy person who has treated them for the aftermath of their treatment. Okay, next. Okay, so this I just want you to show you different variations of scarring and stenosis. The first slide on the upper left is normal. Over on the right, there's a scar at the very opening of the vagina. On down from there, we have a long, they call it a scar. I'm calling it a scar. It's for fibrosis, stenosis, same. And then over on the other side, you see you have an upper scar. And I want to say for women, you might get an older woman, it's like, well, I don't care. I don't use my vagina anymore. Well, actually, you want them to care, because if a woman has had a ovarian, endometrial, or cervical cancer, then you need them to be, and your gynecologist wants them to be able to have a pelvic exam to see how they're doing. So it's really important. Okay. So questions to ask the vaginal patients, female patients. Are they having enough lubrication during intercourse? Is penetration painful? For males, is erectile dysfunction an issue? And I'm, again, male and female, and I think I've already said most of it. So this is all a repeat. So as you can see, the different pelvic cancers have almost exactly the same questions and frequently similar kinds of treatment. So hopefully that makes it easier. All right, so on to the next. Let's see, that's 40. That's my dilator slide. I don't want to miss my dilator slide. Yeah, you're almost there, 40, slide 40. Yeah, okay. So if somebody has had radiation, highly, highly, highly recommend that you recommend a vibrating dilator. You would use a low frequency vibration, and it does help to reduce the fibrosis formation. Obviously you're going to start with a small dilator and work up to hopefully a medium. And I'm showing this dilator because it's one of the better ones. It's got a handle that blends in with the dilator itself. Most dilators have a handle that is separate from the dilator itself, and the dilator has this rim around it that can jam into very delicate tissues if you're not careful. So just my plug. All right, next. So what can we do? So we can be advocates for improving diet. Adequate fiber and fluid is super, super important, especially for those who have either diarrhea or constipation. Avoiding the soda as much as you can get them to avoid it. Full sugar, yuck. Artificial sweeteners are, I know I'm exaggerating, but I'm going to say death to the gastric tissues. They're very hard on the gut, and certainly are not going to do any favors for somebody who's had cancer treatment. There's abdominal massage and positioning for defecation. Here I'm going to say the United States, and I don't know, maybe in Europe too, that everybody's really gotten on the squatty potty bandwagon, and it really certainly does make a difference. So to reduce irritation to the bladder and the urethra, adequate fluid, reducing or eliminating caffeine, carbonated beverages, spicy foods. For vaginal hygiene, really important to tell your patients, do not wipe, pat dry, rinse with warm water. I beg my patients not to use soap, not always successfully. Soap can be very drying, even the kind that's touted as safe for delicate tissues. Fabric softener, thongs, tight pants, shaving pubic hair can be irritating to the vulvovaginal area. Next. So, here's the this is last but not least. So here's your squatty potty. And then to be a little bit more academic about it, you can see on the left slide, the anal rectal angle is going straight down when you sit upright, although actually this person's sitting slightly forward. And anyways, the one on the right is squatting, and that opens up the pelvic floor. That's the whole point. So really what we should be doing is squatting, but since most of us aren't in situations that we can do that, we'll have to just be happy with the squatty potty. And teaching patients how to breathe, deep diaphragmatic breathing help a lot. And let's go to the next. Okay, so here is the final point, 4 of them. So those of us that treat men and women for pelvic dysfunction can really, truly improve the quality of life for individuals who either have cancer or have had cancer that affects their bowel, their bladder, or their sexual function. And I am a huge advocate for getting our oncology patients service and attention for their bowel, bladder, and sexual function disorders, which for many of them are being overlooked. Pelvic health, neuro, lymphedema, and orthopedic physical therapists really need all of us to be on the oncology rehabilitation team, because every single one of us has something to offer these patients. And the other plug I have is for any of you out there listening who is interested but hasn't really taken much continuing education on oncology rehab, please consider doing so. It is a whole other world that is interesting, stimulating, and is very, very rewarding when you see that you're providing a service that can make such a huge difference. I want to just close off by saying this is a first run at this presentation, and I'm going to be adding a lot more about what physical therapy can do so that there's more detail on it. And if any of you have questions, please email me. And if you want to have some actual handouts or suggestions as what you might be able to do for a patient, please email me. I'd be delighted to talk your ear off or write your ear off. And thank you all for those of you that are here now and for those of you who are listening later.
Okay, thank you so much, Virginia. This was wonderful. If people would like to ask Virginia questions, we can entertain a few questions here, and then I will type her email address on the slide here. If you'd like to talk through your microphone, you may have to turn it on because I see a lot of them are turned off to mute. The other thing you can do is if you have a question, you can go up into the top to the chat line, and you can type in a message through the chat line. So are there any questions for Virginia? Virginia, give me your email address too.
My Oakland one?
Yes.
Okay, I hope it's Pier at oakland.edu.
And these are all small letters. For the font on this is not allowing me to type small letters. It's all coming on with caps. And if you can't reach Virginia, you can contact me at druin@oakland.edu. Are there any questions or comments that people in the audience have about the presentation, or questions for Virginia? In the chat message, there's a question from Nina Bertrand. Have you also considered the hypopressive gymnastic exercises for patients to allow inner and upwards mobilization of the lower abdominal organs following radiotherapy? Is there contraindications to it?
Well, I've got to answer that and say, wow. Would you please send me an email with that hypopressive what? Gymnastic?
Hypopressive gymnastic. Can you see this on the screen? The chat? No? Okay. If you slide up to the top, Virginia, there's a chat button where you can see it. So the menu at the top, it's on the right. It says chat.
Okay. I don't have it there.
Okay, maybe she just...
Anyway, I am not familiar with the hypopressive device that you have mentioned, but boy, am I going to be familiar with it within the next 2 days. And I'd be happy to talk to you about that. I'll send you an email.
Nina says she will send it. It comes from Dr. D. Gasquet and Mr. Calfries. It is widely developed and used in Europe. And then there's another comment. Hi, Virginia. Thanks for an erudite presentation. We'll be sending you an award certificate on behalf of our interest group. So this is Nina Chigbo from Nigeria. She's our educational director. And Virginia, you're going to get the International Scholar Award for this. Congratulations.
For real? Is that a joke?
No, it's for real. Oh. And Nina sent back in the chat smiles. So happy days. Any other comments or questions from people?
Well, I'm going to comment. Listen, you guys, I would love to hear from you. You don't have to hear. You don't. If you don't want to say anything now, that's fine. But I am so curious, like what people are doing either across the country or, you know, around the world, because I'm already so fascinated. Like, wow, I've never heard of this kind of therapy. We're not doing it in the United States, and maybe we should be. So I think the more that we share information, the better, because then we can have a bigger pool of treatment sources and referrals and all of that.
Nina does say, thank you very much for this extremely technical and interesting presentation. And you know, me being a person who likes to get people together, maybe this should somehow form a network, some kind of a network on email, or, you know, I can look and see what our resources are within the World Congress. But, you know, anytime you have a small, dedicated, and and very precise group of people that are interested in a topic. It helps to network because then you can share resources, just like the one that was shared about the gymnastics techniques.
Yeah.
So Virginia, the gauntlet is down. We're going to have to form a network for you.
Okay. There you go.
Any other comments? I'd like everyone to, well, first to thank everyone for being here and participating in this. And there will be a recorded link if you want to go back and look at things, or if you want to share it with other people. The link will be up on the website, the World Congress for Physical Therapies. It's called IPT HOPE, which is International Physical Therapists for Oncology, Hospice and Palliative Care, and HIV/AIDS. So I'll put that up here too. So it's the WCPT IPT HOPE. And if you Google it, it'll take you right to our website, and then you can get the link to this. There is another chat question from Allegra Adams. I do not use the abdominal hypopressives. Oh, she does use them. I'm sorry. I do use the abdominal hypopressives.
Are they helpful?
Hi, Jackie.
Yeah. Hey, Allegra.
Hey, I got my microphone on. Just to address Nina's question, can you guys hear me?
Yes, we can hear you.
So yeah, we do use the abdominal hypopressives here at University of Michigan with our pelvic floor program. And so the APTA is going to poo-poo them because of the lack of evidence. I know that internationally they're being used a lot, and we do use them here just because of the significant improvements we are noticing in pelvic organ prolapse, bladder control. We do have a kind of other sub-protocol for abdominal gymnastics for constipation. I haven't used for that as much. I tend to use more visceral and craniosacral with my constipation patients, but in terms of the other diagnoses, we're seeing really great things with the hypopressive.
Oh, that's excellent. Good. So
Allegra, you do need to publish.
There's so many things I need to publish.
Well, let me know. I'll help. Anyone else have any comments? There's one from Nina. Sorry, I don't have a microphone, sadly. It sounds really interesting what you said about your institute using this method. I'd love to hear your findings in this field and clinical results. So, you know, you did express it verbally. And then Nina indirectly is saying you need to publish.
Oh, from the hypopressive stuff?
Yep.
Here, Jackie, I'm going to put my email in, and then you can pass that along to Nina somehow.
Okay. I know how to reach you, Allegra. So
okay.
Okay. It's alad@medumish.edu. So is it okay if I put it on the screen, or?
Sure.
Okay.
Oh.
At med.umish.edu, is it?
Yes.
Okay.
So one thing I do want to add for anybody who's still here, you know, there, at least in my neck of the woods, there is a lot of like, oh, if you have pelvic floor dysfunction, if you have incontinence, just do your Kegels. And I'm literally begging any of you that are listening or listening later on, please don't just give somebody Kegels. Most of the time, individuals may not be clear on how to do them. If they've had cancer treatment, or surgery, etc., they are more than likely very hypertonic, and the pelvic floor is not contracting well or relaxing well, and the last thing you want to do is give them contractions to do that are going to tighten them up. So give them pelvic floor stretches instead.
Okay, there's another comment from Nina Chekbo from Nigeria, and she regarding the hypopressive that is mostly used in post-birth rehabilitation in France, but she believes it really sounds like a great method to use in the context of radiation therapy, considering the counter effects of the pelvic floor organs. And I think you're talking hypopressives, Nina, or are you talking about the gymnastics? And I'll wait for her to type in a response. And I'm not seeing a response yet. But, you know, I think this begs a network so people can share information globally and, you know, talk about treatments and what works for them and what doesn't work, because this is a whole area that, you know, some of the things that University of Michigan is doing. And I think if other people, you know, have it out there, it's not going to be just in isolated pockets.
Right.
Okay. I don't see a message yet from Nina. Any other comments? Questions, chats? I thank you all for being here and staying for, you know, we went a little bit over, but that's Virginia, not me. Which is great. It's great. So if there are no other comments, we do have Virginia's email, and we'll see what we can do about continuing a network on this, because, you know, this is such a specialized group working with such complex problems, and it's good to be able to talk to other people that do what you do. And I know for me, having the World Congress, I've learned so much from people in other countries about ways to, you know, manage some of the conditions or questions that I have related to research as well as rehabilitation. So if there are no further questions, you can certainly continue this through email with Virginia or myself. And then I will be bidding everyone a good day, and hopefully we will see you again at another session. Also, the World Congress is going to be having their meeting in Geneva in May next year, and several of us are going to be putting on focus symposium relating to exercise guidelines. Virginia's going to be submitting one on pelvic health and advocacy for patients. And then we're also going to be having one that is advocacy for lymphedema from different countries. So I bid you all adieu, and thank you kindly for our coming to the presentation. And thank you again, Virginia. This was fabulous. Okay. I'm going to sign out now, and then I'll get the recording up.
Okay. Should I sign out?
Yep. Bye.
Bye.